Welcome to another DPT student chat. Tonight we are talking with Dr. Heather Hettrick of Bring Hope to Haiti. Bring Hope to Haiti is a nonprofit organization working to help patients with lymphatic filariasis manage their condition. Dr. Hettrick is a physical therapist and wound, burn, and lymphedema specialist with an astounding career history that I'm sure she could summarize better than I could. So Dr. Hettrick, can you tell us a little bit more about your career background and how you got involved with Bring Hope to Haiti?
Certainly. First, I'd just like to thank you all for having me be a part of this tonight. This is pretty great. I actually had the opportunity to be exposed to wound care and burn care when I was still a student back in the day when we still had master's programs. So it was during my master's program where we had a guest lecturer come in and give a 3-hour presentation on wound care. That's basically what we got. And she covered burns and wounds, and I was fascinated by it. So when my affiliations came around and I had an opportunity to do acute care rotation, I jumped at the chance to do this up at a burn center in Washington State at Harborview Regional Burn Center Medical Center, which is one of the largest burn centers in the country. And I knew the 6 weeks was either going to be wonderful, amazing, incredible, or it was going to be probably the hardest thing I ever did in my life. And I absolutely loved it. So I knew from that point on I wanted to do something that involved integumentary dysfunction. And so upon graduation, I got a job at a local burn center. They cross-trained me into wound care. And then later I got cross-trained into lymphedema management. And that's all I've done in the 20-some years that I've been a physical therapist. So I love it. And Bring Hope to Haiti came about actually kind of indirectly through a mutual colleague of mine, Dr. John McDonald, who was instrumental in starting the wound care outreach in the wound clinic that came about after the earthquake in Haiti in January of 2010. And he is a cardiothoracic surgeon. However, he has a passion for wound care and lymphedema and things along that line. So he knew of my background being a certified wound specialist and a certified lymphedema therapist and asked if I'd be interested in heading up a program down in Leogane, Haiti, addressing lymphatic filariasis. And next thing I know, here we are, and we reopened the clinic this past September, and it's been amazing, and it's been a wonderful experience. So it's been pretty much a big honor for me to get to be part of it.
Can you explain a little bit more about what lymphatic filariasis is?
Absolutely. It's a pretty interesting condition. It is a parasitic form of lymphedema. The vector, or the way that it's contracted, is through the bite of a mosquito. So these little microfilariae, these little tiny parasites, are housed within the saliva of a mosquito, basically waiting for the mosquito to take what's called a blood meal. So when the mosquito bites a host, a human host, the microfilariae are transmitted to that human host through the bite, and they have a propensity to live, breed, and die basically in the lymphatic system. Why, we don't know, but they have a predilection to basically live in the lymphatic system. But the interesting thing, it can take over 1,000 bites for somebody to actually become infected. So most of the patients in Haiti in particular were infected when they were children. And because the adult life cycle for one of these parasites is 5 to 6 years, sometimes they don't have clinical manifestations for years after they've been affected. So what's interesting, though, with lymphatic filariasis, it is so it's a worldwide pandemic. There are over 1 billion people at risk for contracting lymphatic filariasis, and when you look at it from a worldwide perspective, 1 in 40 people are at risk of contracting lymphatic filariasis. So in the Western Hemisphere, there are 7 countries that are pretty much affected, Haiti being the hardest hit. And then there's places like the Dominican Republic, which is the other side of Hispaniola, next to Haiti, the other side of Haiti. I believe Honduras, Trinidad and Tobago, northern Brazil. There's a few other places that actually have the same issues that Haiti's dealing with. Interestingly, though, there's a lot of research that has shown we can eradicate it. And through the efforts of the World Health Organization, and in particular in Haiti, the University of Notre Dame has done a lot of work with what's called massive drug administration, where there's 2 medications that they give to every citizen in Haiti once a year, and they do this for about 5 years till everybody's had 5 years of dosage. And what that does is it kills the parasite and it will stop the transmission. So additional cases are reducing as far as the number of new cases that are actually occurring. So they've been tracking that from an epidemiological standpoint. So they believe, and they're pretty on track for full eradication of LF, at least in Haiti, by 2020, which is pretty significant. But the problem is you can eradicate the parasite and you can stop the transmission, but once the damage has happened to the lymphatic system, a lot of these patients are left with pretty severe disfigurement of the limbs and associated lymphedema and all those complications, and there just hasn't been anybody down there to manage that aspect of it, and that's where we came in.
So in class, when you taught us about what you were doing in Haiti, one of the things that I found most interesting and most inspiring was that the ultimate goal is to teach clinic themselves.
Yes.
And can you tell me a little bit more about how you do that and what that involves?
Our main goal right now is ultimately to have this clinic be completely sustainable, meaning that it's self-sufficient and run and operated and managed by Haitian clinicians and Haitian citizens and even some of the patients. So we're there right now to help them with the logistical component of reestablishing the clinic, getting it up and running, creating the protocols, doing the algorithms, starting to track the data from a research standpoint. But our main goal is to go down there and provide the training and the education for the local clinicians so that they can provide and they can do the day-to-day operations. And we have a master clinician down there who is he's basically our go-to person. He runs the clinic and he is our lymphophysiotherapist, as they call him down there. We have a patient care coordinator who happens to be a patient himself, a lymphatic filariasis patient himself. We have a tech who is also a lymphatic patient herself who helps assist in the clinic. And they're providing all the care and the direct patient care on a regular basis every day while we're providing some of the oversight. So the goal is to kind of do that train the trainer model. So we can provide the initial training, the education, and then they're going to continue to do that for as long as it's needed so that in time we'll step away and let this clinic be self-sufficient and fully operational through the systems we've implemented. So it's pretty neat.
Wow, that's really, really cool. Is the clinic that you're operating, is it working in conjunction with other healthcare providers or it's simply under the PT umbrella?
Very good question. Right now it's interesting. Leogane is just east of Port-au-Prince, which is the capital of Haiti. And it's based at the Hospital St. Croix, which is the main hospital in Leogane. And Notre Dame, back in the 90s when they started the massive drug administration, all this, built an annex. So kind of like a clinic that's attached to the hospital. And this is actually the physical space where the clinic is located. For a long time, they were providing care for these patients, and then funding unfortunately ran out, and the clinicians that were there were no longer available to provide treatment. So once all that ceased in 2009, so none of these patients have been receiving the manual lymphatic drainage and those other components of lymphedema management since 2009. But the physical place is there. And part of what we're doing now is we are working on getting people that are already certified in wound care or already certified in lymphedema or looking to become certified. We, through the International Lymphedema Wound Training Institute, can provide a dual certification in lymphedema and wound management. And then you can go down and earn your hours to come back and sit for the National Lymphedema Association national exam through LANA. You can go down and practice those skills that you've learned or that you've learned in the past on real patients, pretty complicated real patients. So it is a multidisciplinary approach, a lot of physical therapists, some occupational therapists. There's going to be, we've had some nurses, some doctors, but right now it's pretty rehab related, which is pretty great. But it's a perfect fit for physical therapists, really, when you think about the integumentary dysfunction and then the impairments associated with the complications of lymphedema.
Yeah, wow.
So, yeah, that's neat.
Sorry, Jocelyn, I didn't mean to cut you off there.
Oh, no, it's okay. That is so great that you can do your certification hours through there. For PT students, what do you think is the value of doing like a service learning kind of experience or project with a place like Bring Hope to Haiti?
You know, it's an amazing experience. Where else can you go and just get such an appreciation of how fortunate we are to have what we have here in the United States, but also to be able to make such a difference for another group of people, and to experience other cultures and to experience other ways of life, and to just take your expertise, whether you're brand new at this or old like me, and be able to provide those services to people who really, really need it. It's pretty amazing. So service learning is a wonderful opportunity, I think, for PT students and PTs that are seasoned PTs to be able to give back to the communities, whether it's local, whether it's abroad, and it really is internally rewarding to do something like that. It's a very, very much of a humanitarian spirit, and the difference you can make usually by doing something so simple is it's pretty amazing. And for PTs being such a creative group that we are, it's amazing how you can come up with treatments or creative solutions when the resources are just basically non-existent. And that's where the art and the creativity really come in, and that's where it can be a lot of fun. And I fully support service learning. I think it's an amazing, amazing opportunity for people to get involved in, whether they do it, like I said, in very challenging areas or a little bit more locally in areas that may not be so challenged from a resource perspective, but highly recommend that people can do it if they can. It's a wonderful experience.
Can you think of an instance or anything when you were in PT school or when you first got involved in Haiti that kind of made the biggest impact on you?
Yeah, probably with the Bring Hope to Haiti, well, there's a couple things. With the Bring Hope to Haiti project, it was an overwhelming project to take on, especially because right now there's really 3 of us or 4 of us that are doing this whole thing, and then we have our clinicians down in Haiti. And I think what was amazing with all of the stress of the logistics and the planning and the travel and the, oh my gosh, here we have to do this and this and this, when you get down there and we actually got to see these patients and you got to realize that you rekindled hope in these people, that was the most rewarding thing, because there's such a social stigma with lymphatic filariasis in and of itself, let alone in a place like Haiti where there's a lot of cultural differences. There's still a lot of voodooism that goes on down there. So these people are very socially isolated and have basically been living with this condition because they've been told there's nothing that can be done. And we're coming down there and saying, well, yes, there absolutely is something that can be done. We're making tremendous gains. We were just there a few weeks ago, and we were starting to see reductions in limbs by 10 centimeters after 2 days of treatment. That's pretty significant. And so when you see that and the patients can experience that and realize that there's stuff, the things that can be done, and there's people that care, it's just incredibly rewarding. So that was hugely inspiring to be able to be a part of that and to say, hey, we're helping to shape this and be a part of this great project and hopefully change the future of a country. And I think from, as a student or from in my experience with wounds and burns and things, what's amazing to me and what I encourage other PTs that are curious about wound care but aren't so sure is to, keep an open mind, because where else can you really save a limb and save a life, where you can make a difference in somebody where normally they might have gone on to a severe infection, they might have ended up with an amputation. And just by knowing the right things to do and the sequencing of the right way to do things, you can literally their limb and literally save their life. And to me, that's been extremely rewarding, where patients come in and they say, I'm coming to you because everybody else said I had to have an amputation. And it's like, well, we can fix that. So, it's wonderful. And if you're visual like I am, it's a very rewarding field because you can literally see what you're doing, if it's working or if it's not, because you interact daily with the skin. And that's pretty fascinating too.
Mm-hmm. Wow. So in Haiti, is the organization pretty much volunteer driven?
Yes, we're our clinicians down in Haiti. We are covering their salaries. So we pay our master clinician, we pay our patient care coordinator, we pay our technician, and because we want, again, to support them, basically through salary support to do this job and to keep the clinic functioning and running. And the rest of us are volunteers, and the opportunity to volunteer during medical missions is available. So whether you're already a lymphatic therapist or a certified wound therapist or looking to become a trained person or trained therapist, even as a student, that's something that we can facilitate and help you with. and then be able to have you come down and volunteer for a week or two, depending on what your time allotment would commit to go down and help at the clinic and get those hours and really work with these patients and really make a difference and experience something that is very difficult to put into words. So, but it's a wonderful opportunity.
How else can people help? I know you have a cash donation site, but do you take donations of products and things like that?
Absolutely. We are grateful for anything and anything people will do, even just spreading the awareness of our project and what we're trying to do. We are going to be revamping our website and revamping our blog over the weekend. But yes, we are definitely always in need of funding for sure. And any cash allotments, donations, small or large, every penny counts. So that's always helpful for us too, because it will go right into the clinic, right to salary support. Other things that we look for too, that we need, is when the volunteer groups go down, we stay at the guest house at the hospital, which is basically the second floor of the hospital, which has been converted, old patient rooms that have been converted to like a little hotel, essentially. So room and board is covered when you go down there, and it's in a secure area right on the hospital campus with direct access to the clinic, so you don't have to worry about walking around town or anything along that line. So the guest house needs items. They need pillows, they need linens, they need towels, kitchen supplies, things along that line. I can provide a list of things that are needed. And then as far as the clinic, antifungal powders are needed, short stretch compression bandages are needed, some basic wound care supplies are needed. I mean, anything and everything is needed. So, whatever, if anybody's interested in doing anything, they can always contact me. If they have ideas or things that they want to do, of course, in different ways to support, I'd be more than happy to talk with them about ways they can do that as well. But I think one of these things is just the more people that get involved and do little things, it'll make a huge difference. So our annual budget is actually pretty small from an operational standpoint when you compare to other things, but our main piece is to support our clinicians down there for salary support, and then we do a monthly clinic contribution that covers things like electricity and maintenance, laundry, those types of things too, so that the hospital doesn't have to front those costs to keep the clinic running. And then there's things too, like if somebody's interested in sponsoring a volunteer, interested in sponsoring the clinician, that can be done too. If they want their monies to go to a certain thing, we have an identified custom shoemaker down there that for some of these patients that need custom shoes because they can't fit shoes, we could then use that money to provide shoes for a patient that desperately needs them. So there's a lot of different ways to help and get involved for sure.
So while you were listing all those different kinds of supplies, I was thinking, what kind of functional impairments do people with lymphedema encounter that you might not think of besides the obvious disfigurements and things?
That's a very good question. If you can imagine, now with lymphatic filariasis, there are 7 stages of severity, with stage 1 being minimal, very minor swelling that tends to resolve overnight. So it's very insignificant amounts, all the way up to stage 7, which these patients have such large extremities, severe elephantiasis, that they're basically completely immobilized and they can't move around. They can't get out of bed. They're completely confined to their homes or to their living environments. And then you have everything in between. So a lot of the impairments that we see have to do with gait, have to do with balance, has to do with coordination. It's not painful unless there's an infection, but there's a huge amount of discomfort if you can imagine carrying around 40, 60, 100 pounds of fluid in your extremity. So they do have some orthopedic impairments from kinetic change alterations, the biomechanics of the foot that get thrown off that affects the entire kinetic chain. So there's a lot of those types of associated impairments. And then from a skin impairment, these patients are at great risk for infection. So we do see a lot of cellulitic attacks, or what they call acute attacks, that often require hospitalization. So the impairments can be pretty significant. And if they have other comorbid conditions like congestive heart failure, diabetes, or things along that line, it can just add to the complications.
What's the largest turnaround that you've seen in one of the patients there in Haiti?
Oh boy, so far our patient care coordinator, he has stage 5 LF, which is pretty severe, and I can share some pictures with you at some point. We worked with him on an intensive when my colleague and I were there in January, and in 2 treatment sessions, the largest circumference of, I think it was around his knee, was 83 centimeters, and we got it down 10 centimeters in just 2 days.
Wow.
So, and that was in 2 days. So, usually the way that the treatment goes, in a perfect world, would be 5 times a week for 2 to 6 weeks, and it just doesn't work that way in the real world. So when we go down there with the volunteers, these patients will get daily treatment, or twice a day treatment, because we can do more of an intensive that way. And then when we leave, then Claire's our lymphophysiotherapist will continue working with them to get them down to a more manageable state. So typically what we're seeing on average after about 2 weeks is we can see anywhere from a 20 to 50% reduction, which is pretty significant. Now, we're still getting data that's coming in because we literally just started recollecting or started collecting data as of September 1st when the clinic relaunched. But the difference is that we're seeing so far has been pretty significant. Patients can start wearing shoes again. They can start wearing clothes that they couldn't wear before. They can move around a little bit better and things along that line. So, and for them, when they actually see that, wow, something's working, they get really excited, and get even more motivated and want to do even more. So it's pretty great. It's just amazing. And I was telling somebody before, what's neat too when you're doing the treatments is sometimes you can actually feel the tissues change through your hands. You can feel the hardness becoming softer, and it's an amazing feeling because you really it's working,
Are those improvements temporary, or do they come back after a while, or once you solve it? How does that work? What's the long-term effects of the treatment for them?
Excellent question. It depends on how much they follow through. So basically, usually with lymphedema management, regardless of the cause, whether it's lymphatic filariasis or due to breast cancer or due to some other conditions, there's 2 phases of therapy. The first phase is very clinician intensive. So the clinician will be doing a lot of skin and nail care. There's manual lymph drainage. There's the compression wrapping. There's exercise, and tons and tons and tons and tons of patient education. And that continues until the patient basically plateaus. And they plateau if you take measurements and they haven't changed in about 2 weeks. And then at that point, the therapy then goes into the second phase, which is more patient-driven. So now the patient does a lot of their own management. So now what they'll do is they'll continue with self-manual lymph drainage, which you've taught them how to do. They'll continue with the bandaging at night, and they'll wear a garment during the day or some type of compressive device during the day. They're well educated about skin and nail care. They know their exercises. They know about diaphragmatic breathing, and they can continue to get reductions over time. And the more adherent they are to the protocols and the treatment plans, the less likely they are to have an exacerbation or have it come back. Now, we cannot cure it, but we can manage it. So, but it does require management for life.
Sure. How difficult is it to educate these patients with, I would assume, some sort of a significant language barrier?
Yeah, that's another good question. The wonderful thing is our master clinician and our patient care coordinator not only speak French Creole, which is what most people down there speak, besides French. They also speak English, which is great. So when we go down there, we also have interpreters, which help us a lot. So some of the patients can speak English, and that's helpful, but a lot of what we're doing too is developing educational materials in Creole, and we are we're trying to learn the language ourselves so we can be better. It's just, time. It takes time. But the patients are extremely receptive. And what's interesting is the guidelines that exist out there now for lymphatic filariasis are basically focused around, hygiene, skin care, recognizing signs of an acute attack, elevation, things like that, and they've basically discounted the fact that you should be doing any type of manual drainage or compression because they feel patients won't do it, they won't have access to these products, and in hot climates or in tropical areas, they're just, that for some people they say it just doesn't make sense, and we question that. We said, well, but we know these work, and why would these essential components being left out? So we're kind of rewriting the protocols and saying, you can do this and you can do this successfully, and the patients do comply, and look at the outcomes we're getting. So I think we're kind of changing the face of how lymphatic filariasis should be managed. We've actually been asked by the World Health Organization, my colleague and I, to rewrite the chapters on lymphatic filariasis and another type of lymphedema called podoconiosis, which is a lymphedema induced by a particular soil found in farming areas like in Africa. And basically what we're hoping to do is prove through the protocols, the modified protocols that we've been creating, that no, you can apply the traditional principles with these individuals in resource poor nations and get tremendous outcomes. We just modify the protocols a little bit.
Sure. Wow, that's really, really cool.
Yeah, it's neat.
When you first started working down in Haiti, were there a lot of barriers with getting people to understand that having lymphatic filariasis wasn't because they maybe did something wrong, it wasn't, out of their control, and that it was something they can actually manage? And if so, how do you communicate to people that, you are in control of helping yourself be better?
Yeah, that's a great question too. Fortunately, before we got involved, Notre Dame has been down there for many, many years, since the late 90s, doing a lot of education and doing a lot of outreach, providing a lot of information about what this is, and providing the massive drug administration. So there's quite a bit of awareness there, but there still is that social stigma. A lot of the patients or a lot of the people do feel that, they did something, or they've been cursed, or they've been whatever you want to call it, whether they believe in voodooism or whether they believe in other things, that they don't always understand exactly how it came about. They do know that the mosquito is the problem, but they wonder, well, why do I have it yet this person doesn't have it, and we grew up together type thing. So there's some challenges in that. So when we got down there, I think we had an advantage in that there had already been so much done and so much outreach done, but what was missing was the management component. So people were pretty excited to hear that we were coming and getting ready. I think the hard part was we were hoping to get this up and operational last spring. So I know that was a little disappointing for a lot of people when it took us a little bit longer to get it going come September. But we haven't run into too many problems yet. What we have noticed, though, there are definite cultural differences. There's a different way of getting things done down there. Things tend to happen a little bit slower. There's certain processes that have to be followed. And anytime you work with with a foreign country, you have to figure out the right way to go about doing things. And unfortunately, there's still a lot of corruption down there, so we've had to figure out different ways to be able to get the supplies down there that we need, and make sure that we can track everything and know where everything is at all times, things along that line. So we're learning a lot as we go, but it's been very, very well received, and the patients are just so excited. I mean, they line up when they're supposed to have appointments, but when they know we're in town, they're just it's like, okay, it's going to be a long day. But everybody's just very excited that the care is back, and that they know people are there to help make a difference and help them.
Before this, had you done any other kind of abroad projects?
It's something I've always wanted to do. I've always been very, very interested in doing kind of relief work or humanitarian efforts. The only other opportunity I ever had is I did some wound care education down in Trinidad and Tobago through the Rotary, and that was done, oh my gosh, in the late 90s. And that was really, really interesting for me, and I learned a lot there because I went down there talking about all the, for the day, the latest and greatest standard of care, the evidence-based approach to wound management. And it took me about a day or so to realize that the audience was interested, but they weren't overly receptive, if that makes sense. And part of it was that they understood. It wasn't a language barrier, but they just didn't have access to a lot of the things that I was talking about. And so when I realized what had happened and realized the disconnect basically because of my assumptions that were wrong, I kind of stepped back a little bit and made it more interactive and asked them, well, you tell me, what do you do when you have a case like this, or what do you manage? And I learned more from them. So back in the day, we had an enzymatic debriding agent that had a papain-based product in it, and it would help enzymatically break down necrotic tissue. And they said, oh, well, we don't have that, but we take fresh papaya and we make a poultice and we put it right on the wound and then we wrap banana leaves on it. And I'm like, and it makes a tremendous, and it worked, So we ended up sharing, like, this is what we do, what do you do? We talked about, understanding about moist wound healing principles and the importance of debridement, but I basically had to just get rid of everything I had prepared and kind of speak on the fly because it had to be meaningful to the audience. So that was an interesting learning experience for me, because sometimes you go down there with the assumption of, oh yeah, well, they'll be able to da-da-da, but not in a foreign country. They don't have the same products. A lot of times they don't have access to them. It could be the cost. It could be that they're not available, whatever the case may be. So that was an interesting experience and not a mistake I'll make again. So the point is with that is always to do some research before a time, find out, what your audience needs, what they're looking for, what they have access to, so that you can kind of customize the presentation and make it more engaging and more meaningful, so that they actually have those clinical pearls that they can start using literally the next day. Because it's not appropriate to talk about things that they just have no access to. So that was a good learning experience.
So would you say that your involvement in Haiti has helped you grow a lot as a physical therapist?
It absolutely has. It really just gives you perspective. Like I said earlier, it just makes you appreciate, as much as we complain about healthcare here, it does make you appreciate a lot of what we do have, our access to things, just seeing the way other people live, especially in a developing country that is so resource poor, and dealing with a neglected tropical disease such as lymphatic filariasis is very eye-opening. So it's definitely helped me professionally, but personally, just gain an appreciation and really continue to realize what's truly important and be grateful for what we do have. But it's also rewarding to feel that I can take some of my expertise and give back to people, whether it's patients in Haiti or train other people and share the mistakes and share the knowledge that I've gained over the years to maybe help other people not do the same thing or advance their own, their own experiences in their own profession as well. So,
if a PT student was considering wound care or lymphedema management or anything, what advice would you give them?
Well, first of all, I say yay, because obviously I love it. I'm passionate about it. I think I would tell any PT student to keep their eyes, keep their minds open, keep their options open. If there's an interest in it, to definitely explore it. I can say that it is a wonderful practice area for physical therapists to get involved in. Not a lot of people do it, not because not a lot of people like it, or not a lot of people have ever had the experience of even knowing if they're going to like it. So it's wonderful because it can give you a whole nother niche, a whole nother way to market yourself as a PT. It's an area where you can do this full time. It's an area you could do it part time. It's an area where you could just do consulting. It kind of depends on what your preference is. But I would say absolutely, and particularly in something like lymphedema, because there is such a need for therapists, lymphedema therapists out there, because there's so many patients with the condition that need help that just aren't getting the proper care that they need. So the patients are out there for sure, and the opportunities for PTs in this practice domain are tremendous. But particularly when you start looking at the aging population, the demographics that are changing, the diseases that patients are living with now, and how many of those can contribute to integumentary dysfunction. There's just a lot of opportunities for PTs to be involved in wound and lymphedema and even burns, and it's a very, very rewarding area. And particularly if you're visual, and if you really like to, you can save a limb and save a life. And I encourage anybody to get involved with it or learn more, get additional training beyond what you get in school.
Heather, do you remember kind of your aha moment? A lot of us in school kind of have a general, I think I might like this, but I haven't seen that. What was the aha moment for you where you were like, wound care is my thing that I'm passionate about and I'm totally jumping in?
Absolutely. When I was in PT school, I wanted to work for a professional football team. That was my thing. That was what I was going to do, and I was gung ho on it. Orthopedics, sports, medicine, blah blah blah, like a lot of us. So, and I remember my now one of my best friends, Tracy Mullen, came in and she was our guest speaker one day, and she gave us a 3-hour lecture on burns and wounds, and I was fascinated, and not only because she was so passionate about it, but the pictures, I was just like, I never knew. I never knew PTs did this kind of thing, and I've just always been fascinated with things along that line anyway, not knowing I could end up having a career in that domain. And so she was kind of my aha moment. And then I talked to her after the class and asked her, well, what books would you recommend? And if you had an opportunity to go someplace for an internship, where would you go? And I told her that there was the possibility up at Harborview, and she just was like, that's like the coup de grace of affiliations in burns and wound care. So I jumped at that opportunity, and those 6 weeks were the most amazing 6 weeks of my life, and that defined basically the entire career path that I took since then. And I don't regret a thing. It was fantastic.
And once you started kind of working in the wound care setting and you knew it was for you, did you immediately start working towards your specialization?
Yeah, I basically started as a burn therapist out in Torrance Memorial Medical Center in Torrance, California, in the South Bay. And they had an 8-bed burn unit, so I started there, and then they cross-trained me into wound care. So out there in California, particularly at the time, it was a PT run outpatient wound management program. We did a lot of inpatient wound care as well, and then, of course, we had the burn clinic, we had the burn center. So I quickly got cross-trained into burns as well. Into wounds as well. And at the time, it wasn't until 1996 when the first certification came out for certified wound specialist. So I became a certified wound specialist actually in 1997. I've been a CWS for quite a long time. And then, but there were certain things you had to do at the time. So I started working on that out about it. Now it requires about 3 years of experience and things along that line to sit for the CWS exam. And then when I used to be a professor up at New York University, and they sent me down to get trained for lymphedema. And that was a phenomenal experience for me. So they provided the training and and had me certified in manual lymph therapies and complete decongestive therapy, and I got my CLT while I was at NYU, and that actually was great for me because it led to my dissertation topic when I was working on my PhD at the time. So and really what happened with that too is wound care and lymphedema and the integumentary system and the lymphatic system are so intimately related that they should be taught together. And so that's been something that I've been working on for quite a while, and now at the ILWTI, that International Lymphedema Wound Training Institute, they're the first group to actually pull the two together and offer a dual certification, which is pretty neat.
Oh, that's cool.
So, yeah.
Neat.
That was going to be my next question, was what kind of certification would you suggest a PT student look into after graduation if they wanted to go that route? So it would be through...
There's different routes to go. I do have to disclose I am a former board member of the American Board of Wound Management, which offers the CWS, the Certified Wound Specialist, the Certified Wound Care Associate, and the Certified Wound Specialist Physician credentials. They're strictly a credentialing body, so you can go to the ABWM website, and there's a lot of information there about how to get credentialed as a certified wound specialist. I highly recommend that route because they've been around the longest. They're highly reputable, and it's a multidisciplinary certification, which is the way you manage wounds anyway. You have to have a team approach. There are other methods too for physical therapists, such as the Wound Care Education Institute. They provide the wound care certification, the WCC, and I believe that's the National Alliance of Wound Care and Ostomy. I'm sorry, I can't remember it off the top of my head, but if you do if you do a Google search on wound certifications, the ABWM and the Wound Care Education Institute are the main two that pop up, especially for physical therapists because they're both a multidisciplinary certification. The nursing had the WOCN, which is the wound ostomy continence, but that's not something we can sit for because we're not nurses. And then there's the newer one, which is through the International Lymphedema and Wound Training Institute, which does a joint dual certification in lymphedema and wound care, which is, and you can check that out on the ilwti.org website or .com website. And then there's a lot of traditional lymphedema certifications that are out there. The Academy of Lymphatic Studies. There's the Klaus Training Center, which is KLOSE. There's the Norton School. There's a lot of different philosophies and a lot of different ways to be treated, but they all require a certain number of didactic hours and a certain number of hands-on hours. And then once you get certified, then you can obtain your practical hours and then sit for the national certification. So there's a lot of information out there. I do highly recommend, though, if somebody's interested in pursuing lymphedema, that they consider also wound care, and if they're considering wound care, they also get cross-trained or certified in lymphedema because they are so intimately related, and you can provide such a service to these patients because it's rare to have a lymphedema patient without skin issues, and it's rare to have a lot of our wound patients without lymphedema issues. So it's just a natural fit for both of those. And as far as the marketing niche for you as a PT, you could pretty much write your ticket.
Are there a lot of dedicated wound care and lymphedema treatment centers, clinics throughout the United States, or are they kind of...
Yes and no. No, yes and no. There's the trend lately has been there's a lot of national wound centers, and a lot of them are managed because they provide hyperbaric oxygen therapies as well. So there's a lot of big companies now that are either have purchased or have acquired independent like wound centers and wound clinics, so they're operating more at a national level. There's a lot of those that are available, and some of them have PTs as part of the team and others don't. There's a lot of freestanding wound clinics, both that are associated with hospitals but are also outpatient. That some are PT run, others are PT owned, others PTs are part of the team. So there is a variety, and I do recommend for people that are interested in that, the Association for the Advancement of Wound Care, the AAWC. I believe their website's aawconline.org. They provide tremendous resources for people, disciplines who are interested in wound care and learning about wound centers and things like that. They can get information there, and they also welcome students. So as a student, you can become a member of the AAWC at a significant reduction of cost. I think it's like $60 a year, and you get a lot of member benefits that way. But the best thing is to really search out in your practice area, wherever you're living, what's available, and is it a small independent facility, and what services do they provide, and what training do the people have, versus is it more hospital based, and who runs it, what are the protocols, those types of things. But there's quite a few out there, and I think there's more coming just because of the needs of the general population.
Can you tell us a little bit more about the kind of wound epidemic amongst the aging population, and are there any access issues to wound care?
It's a very good question. You guys are great questions. It's interesting. I have a colleague up in Boston who I think says it the best, Dr. Filariasis. He says we're outliving our skin. And I love that quote because if you think about it, more and more people are living well into their 80s, their 90s, their 100s, and our skin has a finite lifespan. We accept heart failure and liver failure and kidney failure, but when it comes to skin failure, this is a very new concept for most people to understand, and we're starting to really appreciate that, and it's starting to become recognized as an entity in of itself, in that we are starting to outlive our skin. So the need for wound care and the need, particularly as we grow and as the population ages, is going to continue to expand, because at any given time, there's some staggering data. There's over, more people suffer from chronic wounds than Alzheimer's, Parkinson's, ALS, and most forms of cancer combined. yet you don't hear about it as a problem like you do ALS or Alzheimer's because we don't have a face. You know, nobody wants to be the face of a wound. It's just not a sexy thing, you know. So and people tend to hide it when they have a wound. They don't look nice. The wounds don't look nice. You know, they drain, they can smell. So it can be very socially isolating, but we have a tremendous number of people out there with wounds. You know, 70% of people over the age of 70 will develop a pressure ulcer. In patients with diabetes, 25% of them will develop a foot ulcer at some point in their life. And of that, 16% will go on to develop an infection, or sorry, 15% will go on to develop an infection, and from that, 16% of those will develop an amputation. And then the morbidity or the life expectancy after a foot ulcer is about 30 to 40% in the first year, and it can be as high as 80% by 5 years. So it's devastating, and there's no reason for it. And then that's not even factoring in peripheral vascular disease, which affects millions of individuals. So there is a huge need for people that understand how to manage wounds and how to address the underlying comorbid conditions. And for PTs, I think what makes us so perfectly positioned for this is a chicken or the egg. You know, is it the wound and the skin dysfunction that led to the impairment, which can happen if you have a painful wound, or you can't walk on your foot because you have a wound, or you had a surgical wound that dehisced or opened or had complications. So that's leading to the functional impairment. Or is it the functional impairment that led to the skin dysfunction? So if somebody's in an accident and they're you know, confined, or they're immobile for a while, and then they end up developing a pressure ulcer, or they end up developing other complications with their skin, we as PTs, we can manage both of those. And I think it makes it very cost-effective, resource-efficient for people to receive that kind of care from people that understand the full picture. And what I always like to tell my students and my patients too, and quote another colleague of mine, Carrie Sussman, is she says, it's important that we treat the whole patient and not just the hole in the patient. And you've probably heard that from Dr. Gibbs, I'm sure. But I think it's an important thing to consider, because you know, you don't want to just focus on the diagnosis. Why are they coming to you? You've got to look at the entire picture, and for better management purposes.
Are there a lot of insurance company reimbursement issues with wound care?
There's always issues with reimbursement. you know, in anything. Reimbursement changes. I think a lot of it right now, one of the things that we're facing from a PT perspective is the G codes, or the functional reporting that we need to do in outpatient. And a lot of that is really right now for Medicare and Medicaid to kind of collect data and kind of see what are PTs doing? What kind of conditions are they treating? What is the duration of care? What are the interventions that they're doing? So they can kind of really figure out how to most efficiently reimburse and pay for services, given that there's a finite amount of funds out there. So reimbursement is always an issue. The APTA does a phenomenal job. The Clinical Electrophysiology Wound Management Special Interest Group does a phenomenal job advocating for us on our behalf to keep reimbursement for PTs in particular, but for wound care in general. The AAWC, as I mentioned before, they do a lot of what's the word I'm looking for? It's not political action, but they're part of just staying abreast of a lot of what's coming down the pipes from reimbursement standpoint. And I'm blanking on the task force, which is a little embarrassing right now. But a lot of people are very involved in staying on top of what's going on with reimbursement and the changing rules and the different things that they'll cover and other things that they won't cover, and things along that line. But it's still what they're realizing, and they being CMS or Medicare, is that there's been a paradigm shift of late where they're starting to recognize the importance of prevention, and that's a huge change where Medicare used to never pay for anything that was preventative. So that's a real positive thing, and they're starting to see that if you do something that might be a little more expensive up front, you're actually saving significant dollars down the line, and so that's something positive that we've been seeing lately.
I have a question for you. You're the professional here. You're a specialist, obviously. You've been in the field a while, and you've seen a whole bunch. What have you seen in the literature from colleagues, things like that, as kind of the cutting edge feature of wound care? What's on the horizon?
Wow, lots of cool stuff, actually. Stem cells. Stem cells are definitely on the horizon. We have a lot of new products now from amniotic tissues. We have cellular and tissue-based products, which are becoming um, really, really amazing as far as the benefits that they're doing with skin and uh, helping to expedite wound healing process. We're starting to see a trend towards personalized medicine, where basically what they'll be able to do is from the genetic code of the person to be able to customize dressings and customize topicals to specifically address the impairments that are going on with that person given their wound and what's presenting in that wound. We're going to see a lot of really interesting bedside clinical diagnostics, things like literally like strip tests where you can dip the little stick in the wound and it will tell you what's growing in the wound right there at the bedside. So a lot of pretty fascinating things. Recombinant type therapies, a lot of advances in topical medications, topical applications, biophysical agents, things along that line. And then we're seeing a lot of really old school things come back too, such as maggot debridement therapy, honey-based products. Some of the tried and true things that have been around for centuries and centuries are starting to come back because they're very, very effective. So it's a rapidly growing, highly exponential growth as far as research and development within wound care. And what I'm interested in following too is what the impact 3D printing possibly can have on wounds and skin and things along that line. So I think that's really going to be something we're going to see just take off in the next 5 years.
Very cool.
Yeah.
What's the coolest new thing that has happened during your career?
Wow. I think probably one of the most amazing things, that's so going to date myself now though too, is back in the two things. Back in the late 90s when negative pressure wound therapy first came out, KCI had the vacuum assisted closure that came out. We were one of the first clinics in California to actually get to trial the VAC at the time. Now we call it negative pressure wound therapy because there's a lot of different companies out there making the devices. That drastically changed the way we approached wounds, particularly really large defects. So, abdominal wounds that dehisced or really significant like flesh-eating bacteria or calciphylaxis or just massive, massive traumatic wounds. Because of the way it works, it just completely can facilitate the contraction process and build up that granulation tissue so quickly compared to the conventional methods we were using at the time. So that was huge. And I remember when some of the one particular product came on the market when I was still doing burns called Integra, which was one of the first dermal replacement components that we had, because as you know, our dermis doesn't regenerate. It doesn't it heals with scar tissue. So this was a novel thing that was able to mimic the dermis, and the body would incorporate it like a neodermis, and then you would just put a very thin sheet graft over the top of it, and that really changed the way we managed burns. So it's been amazing because the advances are just incredible. Just as far as the dressings that are available, the products that are available, the diagnostics that are available, it's almost hard. And actually it is. It's very hard to keep up with it, even when you do it full time, because the things change so quickly.
Sure.
So we're running out of time. So going back to Bring Hope to Haiti, we have a couple of student questions. One of them: if a student was to volunteer, what skills do they need?
A great question. We also, if a student is interested in volunteering and they don't have a lot of wound or lymphedema experience and they don't have the ability to get trained ahead of time, we definitely can use people to come down and help us with other things. So they can help with data collection, they can help with organizing the clinic, they can help with supplies, they can assist with some of the treatments, things along that line. So there's a lot of other ways for people to get involved. We need people to take pictures, we need people to take video. We're trying to photo document and video catalog the trips as we go down there. So there's a lot of roles things that they could be doing as a supportive role. If they do have the opportunity to go through one of the training programs through the ILWTI ahead of time, that would be ideal, because then they could come down there and work and actually practice and refine their skills. But there's definitely ways for them to get involved, and I can always give more information on how to do that too, or they can contact me directly on how to get more information.
So those programs with the ILWTI, did I get that right?
You did.
So those programs are open to current PT students?
Yes, and that's one of the differences about that. I am, again, for disclosure, I'm a faculty advisor on that with that organization. But what's different with that is a lot of times, a lot of the other groups that are out there, actually you need to be a licensed practitioner, and then you need to have X number of years to then sit for that certification and show that you have a portfolio and that you've done X number of hours or whatever. The difference with this group is they feel that let's train people the right way from the beginning, and then they can go get the experience. So it's a little bit of a flipped approach, but it makes sense to do that. So you get the state-of-the-art standard of care education with respect to wound care and lymphedema management. You come out with this dual certification, and then you can go, even as a student, and then you can go apply those skills clinically, whether in Haiti or some other places where you can then practice and get those hours if you want to then sit for the national certification. So it's a little bit of a different approach, but we feel that let's train people right from the beginning so you don't have to unlearn stuff if you learned it improperly. And it's a pretty neat model. So it's finally nice to see these two merge together, because they do go hand in hand, like I said before.
So what's the best way for students who are interested in volunteering to contact you or the organization?
They can contact us through the through bringhopetohaiti.com or through the ilwtimedicalmissions.com. You can give them my email address at Nova, which is hh124@nova.edu. Like I said, we're going to be revamping the website and all that this weekend, but the information is still there, but we're going to make it a little bit more user-friendly. But they can contact me anytime, and we can definitely get them the information that they need. And there's travel grants available too through our fiscal sponsor, Medi4Help, too. So there's other ways to get some assistance if people can't afford to travel down there or do things like that. So we have a lot of neat relationships and groups that we're working with to really make this successful for everybody.
Great. So we only have a few more minutes, and I know we talked about all kinds of things, but the theme of this talk was how PTs can help change the world. And I definitely feel like Bring Hope to Haiti is one example of the impact that we can have on people and making their lives a little bit better. Do you have any closing thoughts?
I think you're absolutely right. I think, again, we are so uniquely positioned in the healthcare community to do so many things for people, whether it's locally in our own communities or abroad. PTs can participate in health fairs and educational seminars or outreach at schools, and so many different ways to provide education, not just about the profession, but how to improve people's health, how to improve their mobility, how to improve their general sense of well-being. And then I think it's incumbent upon us too as PTs to give back, and what better way to do that through sharing your knowledge, sharing your expertise with other people, or providing those services to people who otherwise would not get those services. So whether you're doing pro bono care, whether you're doing international work such as Bring Hope to Haiti, it's such a rewarding way to give back to humanity, but to the profession and to give of yourself, and it comes back tenfold. So I just think we're so uniquely positioned, being the educators that we are and having the knowledge that we have, that we can just make a really positive impact on people, and it's extremely rewarding. So I encourage all students and PTs, for that matter, to get involved in something along that line, because we have the skill sets to do it.
Awesome. So thank you so much for joining us tonight. That was really, really great. I learned so much.
Well, I appreciate your time and everybody else's time. This is such a great thing you all do. It's amazing. I wish I had this when I was
It's an amazing tool. I've learned so much just hanging out with people on Twitter chats. It's outstanding, and I love it.
Super cool. Well, just the connectivity that it does, just how it can connect people. But I commend you guys on doing